your conference.
And hello, everyone. Thank you for joining us for the latest session of the DaVita PD webinar series. The series covers the key clinical elements of managing patients on PD and is recommended for all DaVita nurses, medical directors, as well as any physician who has or plans to put patients on PD. Today's audience is a mixture of physicians and DaVita teammates, and we're happy to see that there's such growing interest around the therapy. As a reminder, all of our webinar sessions are recorded and available for on-demand access. We'll often reference previous webinars in our current webinar, so please make sure to go back and watch the past webinars so that you'll understand what we're talking about during our reference. Today's presentation will include a Q&A session at the end. You can ask questions in multiple ways. You can wait until the end of the presentation and ask your questions in person, or you can type them into the chat box of your webinar panel, and I'll go ahead and ask those questions for you. You can type those questions into your chat panel at any time. Today, of course, is cruise control, parameters and tips on keeping patients on the therapy for the period of 90 days to 6 months. I'll go ahead and pass our baton on to Dr. John Moran, who will introduce today's speaker. John?
Thank you, Ms. Renaud. It's a pleasure to introduce Dr. Mehrotra, a very long introduction because he has a long resume despite a relatively short career. Dr. Mehrotra is Professor of Medicine at the David School of Medicine at UCLA and Associate Chief of the Division of Nephrology and Hypertension at the Harbor UCLA Medical Center. He chairs the Dialysis Advisory Group of the American Society of Nephrology. He has been admitted to Alpha Omega Alpha, an honorary medical society, and was awarded the Denmar Award by the International Society for Peritoneal Dialysis in 2006. His research support includes, among others, grants from the National Institutes of Health and the American Heart Association. Research interests include determinants of the selection of dialysis modality, comparison of outcomes with different dialysis modalities, outcome studies in peritoneal dialysis, and mineral metabolism in chronic kidney disease. He has co-authored over 130 articles and or book chapters. He is associate editor of NESAP, Center for Clinical Nephrology, and serves as a member of the editorial board of the Journal of the American Society of Nephrology, the Clinical Journal of the American Society of Nephrology, Kidney International, Peritoneal Dialysis International, and Journal of Renal Nutrition. He's the Education Committee of the International Society for Peritoneal Dialysis and a member of the Board of Directors for the International Society for Hemodialysis. Dr. Mehrotra, I hope I didn't take up too much of your time. Please take it away.
And good morning to you guys on the West Coast, and good afternoon in the other time zones. What I'm going to talk to you is about keeping patients on therapy. This is part 1-3. Begin with a disclaimer that the content and opinions of this presentation are mine and do not necessarily express the views of DaVita. What I will do in the next 35 to 40 minutes is to define the problem and point out how common are early transfers to hemodialysis. Identify who is at risk, regards to the facility where they are cared for and the patients themselves, and do patients transfer rather soon within the period that we're interested in today, between 9 days to 6 months. And more importantly, I will focus on strategies that I think could work to reduce risk, and I selected a few. These are not the only few things that are important. There are others that we can discuss if you choose in the Q&A, but I'll focus on CQI, preventing infectious complications, and residual renal function. By saying that many dialysis transfers are preventable. Identical patients in two different facilities provide care by two different physicians. One may choose to transfer that patient to dialysis and other may not. So there are practice patterns that determine whether identical circumstances a patient is going to remain on PD or going to be transferred to hemodialysis. And I think one of the goals of care is make sure that we minimize those transfers to dialysis and point out to you that many of these transfers are preventable. And if you look at the experience within the United States, what is clear is that larger facilities that have more than 24 patients, are less likely for the same patient characteristics to transfer patients to hemodialysis than our smaller facilities. I think, in my opinion, my belief, that many of the transfers to hemodialysis are preventable and or manageable. And what the good news that exists over these past 15 years is that less patients need to transfer to hemodialysis than needed to. This is comparing 1996 to 98, and compare that. These are old data, comparing it to 2002 to 2004. And as you can see, about 30% less chance of a patient starting PD to transfer to hemodialysis, and the outcomes have even gotten better. So we've gotten better in understanding why patients transfer and to keep patients on treatment, and that has to be the central goal of a successful PD program. Transfers are common. In the United States, if you look at these entire national data, out of every 5 patients that transfers within the first 90 days. I'm not going to talk about the first 90 days, but that is a very large probability of transfer within the first 90 days. In my opinion, these patients never had a shot at success with regards to peritoneal dialysis. And if you go on further, if you just go on to experience from around the world, this is from Switzerland and this is Netherlands, and you can see almost half the patients in Switzerland, and there's one unit, transferred to hemodialysis, transferred within the first 6 months. And it's experienced from many centers in the Netherlands. Again, I don't have the data for 90 days to 6 months, but if you look past 3 to 12 months, you have 30% of patients that transfer within the second 9 months of treatment. If you compare it, half the patients that transfer do so within the first year of start of PD. So these patients, in my mind, never got a shot at being successful in doing the therapy, and it is important then to know why people transfer so early and what we can do to minimize that. It's just a summary of some of the characteristics in identifying individuals who are at risk for transfer. Who are these patients? So if you look at the facilities that are more likely to high transfer rate are those that have fewer patients. It varies by dialysis provider, and I have to tell you that DaVita does very well in terms of minimizing transfer patients to hemodialysis, and that's not because I'm a physician or speaking in a DaVita line. I've done research looking at the national data that was not obtained from DaVita, and it actually does very well in this regard. Facilities that are at greater risk are those that are located in remote rural locations. Look at the facility characteristics then. The facilities that are at greatest risk are the ones that least amount of resources available to help deal with complications that may arise with peritoneal. Smaller units, it may be an issue of staffing. Located in remote rural locations may be related to access to, for example, surgical intervention when it may be needed or otherwise, that puts patients at risk for a high risk of transfer to hemodialysis. The patients that are more likely to transfer to hemodialysis are those that are older, that are black, that are diabetic, that are larger body size, or that have been treated with hemodialysis previously. In doubt that the point of showing the slide about which patient characteristics are associated with higher risk for transfer doesn't mean that these patients are poor candidates for PD. They are not. They are as good, in my mind, candidates for PD as the younger individual. What it tells me is that when the patient is admitted to your facility, an old black diabetic individual, for example, the patient requires a lot more support from within the facility to be successful than patients with other such characteristics. But I would not use data like this to say that these patients should not do PD, but these patients do as well if provided with the right support as do otherwise, as do all groups of patients. Now, to understand, so we've defined that transfers occur A lot of them occur early. Why do they happen? This is one slide looking at experience from this one study from Netherlands, and if I could just focus your attention on this bar right here, there's transfers that are occurring because of, these are not transfers, these are patients that die. These are patients that get a transplant. So both of these things are good things. We want to, well, pardon me, death is not a good thing, transplant is a good thing, pardon me. But these are the causes we want to focus on. There's the largest transfer remains infection, followed by catheter complications, followed by psychosocial reasons. And then under dialysis, this very tiny pink line is under dialysis, ultrafiltration failure, and this is abdominal complications. And as you see, infection is the most common reason for transfer between 3 to 12 months, and across times, it is this period of time that infection is most important. So in the first year, if you've gone through the first 3 months, in the subsequent 9 months, infection is the most common cause of transfer. And as you see, if the patient has gone past the first year, infection as a cause of transfer keeps on becoming smaller. This is looking at the catheter complications. Catheter complications are most important in the first 90 days. And you go further away from the time the patient starts treatment, catheter complications become less important. And the dialysis, the psychosocial unknown remains more or less the same. And under dialysis, ultrafiltration problems go up as time goes on with dialysis. And then abdominal complications are important early on, just like the catheter complications are important early on, and the diminishing importance over time. Experience was reported from Switzerland, in which an infection was the single most common cause of failure that happened early on. Catheter problem diminished in importance. The catheter issues are important to be dealt with during the course. Starting PD, leaks, hernias, adequate dialysis are similar. The social problems actually are more common early on than later on. It is the reason that I've decided to focus on peritonitis and residual renal function for the talk that I'm going to present. So if I were to summarize what I've said thus far, is that less patients transfer to hemodialysis than they used to in the 1990s. So if you're somebody who used to take care of PD patients in the 1990s and did not have a good experience with it, be assured that things are different now. It is not the way it used to be as it was in the 1990s. The also thing that transfers to hemodialysis are to a significant extent preventable, not entirely. And the reason is very simple. All have only one peritoneal membrane. If that peritoneal membrane is damaged, there's no choice but to do hemodialysis. If you do hemodialysis, you have multiple vascular access sites. One fails, you can move on to the other. So by definition, PD is going to have more transfers to hemo than the other way around. Even those transfers, they to a significant extent are preventable. Larger units seem to do better than in my mind emphasizes the importance of CQI programs and focusing on practice patterns and complications. Transfer to hemodialysis vary by time on therapy. Catheter problems and psychosocial issues are significant cause of early transfers. Non-infectious complications are equally important across the spectrum of time, and patient problems becomes important later in the course of therapy. So what would then be the approaches to minimize transfers be for the time frame that we are talking about, which is 90 days to 6 months? Absolutely, the most important thing is the CQI process within the unit. Every unit should know your data. How many patients transfer to hemodialysis every year? During the course of time of doing PD do they transfer? Why transfer? So the solutions that I may present today may not be appropriate for you because the causes for transfer may be different in your unit. And the only way you're going to make success out of problems is to know what the problems are that are unique to you and then determine how you're going to overcome them. Design solutions that meet your needs. Do you need a new surgeon. Change the transfer set that you're using. Change how you train your patients. Do you need protocol to deal with contamination? I will talk about that. Are the processes in place to ensure adequate prescription management? Do you standardize process to handle leaks? Do you protocol to maintain patients on PD who, for example, need a hernia repair? A person needs a hernia, does not need to go to hemo for that hernia to be repaired. They can be kept in PD. So again, I'm just going to focus on two issues. One is infections and the other is residual renal function. So let's just talk about preventing infectious complications. To prevent infectious complications, we have to know how infections get into the peritoneal cavity. The most common reason for infection to occur is intraluminal. Intraluminal means that there is a problem with touch contamination. That at some point during the course of doing an exchange, the patient introduces infection inside the lumen of the catheter, and that infection then goes through the lumen of the catheter in the peritoneal cavity. Know that by seeing infections that occur because of staph epi, because of steroids, because of gram-negative rods. You can also have peritoneal infections in which the infection starts around the catheter, start as an infection of the exit site of the tunnel. Then it goes outside the lumen of the catheter into the peritoneal cavity. And examples of that are classically Staph aureus or Pseudomonas. There's a third of infections which is enteric, which is thought to be because of movement of bacteria from inside the intestines into the peritoneal cavity, and classically with gram-negative infections. You can also have it secondary to a pre-intra-abdominal event, that there is cholecystitis, there is appendicitis, there is diverticulitis, and that causes contamination of the peritoneal fluid that then causes a peritoneal infection. It's iatrogenic, and when I mean iatrogenic is that patient gets a procedure, patient gets dental cleaning, patient gets colonoscopy, or gets a GYN procedure done, and that results in infection being introduced into the peritoneal cavity. You could hematogenous. Hematogenous meaning it is in the bloodstream from another source. Somebody gets endocarditis. Somebody has a dialysis catheter that gets infected, and that secondarily involves the peritoneal cavity. I have to admit that intraluminal and periluminal account for 70 to 80% of all infections that happen. And it is important then to focus on preventing intraluminal infections and periluminal infections. In order to prevent intraluminal infection, the first step is we train the patient technique that the patient uses in performing that exchange. And it is important that as part of the training, we teach patients how to recognize that contamination has occurred, and for them then to contact the unit to treat contamination before peritonitis occurs. I also want to emphasize that there are points in time retraining a patient is important. Me, for example, if the patient was admitted to the hospital for 2 or 3 months, and he was in dialysis support in the hospital and has now forgotten the steps, and they may need to be retrained. We read patients that get episodes of peritonitis frequently, and I'll talk briefly about that. The connectivity is less important now because all of us for PD use the twin back system, but it is also very important in my mind that patients that use a cycler, that we do not ask the patients to manually spike the bags, but use connection assist devices that are available to spike the bags to prevent the contamination from occurring at the time of connection and disconnection. This is an algorithm that was developed by Dr. Pereno in the University of Pittsburgh, and this is how to treat contamination. So whether the transfer set comes apart or the mini cap falls down and the patient puts it on or something else happens at home, a critical component of our training is to have the patient call the dialysis facility immediately and what we do depends upon exactly what happened. If the clamp on the transfer set remained closed, the patient should not proceed with dialysis. They call the dialysis center immediately and should start PD again till the transfer set is changed by the PD nurse. If the clamp on the transfer set was open, the patient should close the clamp, not do PD, call the dialysis unit immediately, will transfer set and prophylactic antibiotic. And the antibiotic that we use is cefazolin and ceftazidime peritoneally for 3 days, using dose similar to what you would use for an episode of peritonitis. You can substantially reduce the incidence of peritonitis around episodes of contamination if you follow the process and change the transfer set, and if necessary, give prophylactic antibiotics. So there's about CAPD, APD, and peritonitis, and I just want to already address this issue, and I just want to speak to it just one more time. It is true that a patient that does cycler makes fewer connections and disconnections compared to a patient who does CAPD. To make sure that you have the advantage with a cycler, the patient should use a connection assist device and not manually spike the bags. Instead, patients don't spike the bags manually because now we use the twin bag systems that don't require spiking. Spiking is particularly problematic in introducing infection in patients. With regard to periluminal infections, it is related to catheter implant. It could be related to catheter implantation. The prevention strategies need to begin around the time of catheter implantation. The patient should get a single dose of an antibiotic. We use cefazolin on call to the operating room. It's important that you use 2 cuff catheters for placement, and the exit site is directed either sideways or downward. It is important that the exit site not be pointing upwards. If the exit site is pointing upwards, it is a setup for infection. It's important also to be careful in how you do exit site care early on and in the later period, and then there's this issue of antibiotic prophylaxis. What is important early post-implantation is that surgeon not put any sutures at exit site. We've had trouble with surgeons putting sutures and staples at exit site. We worked our problem through, and we no longer see sutures or staples at exit site. I think it's important for the exit site to heal completely. The patient should not be taking a shower until the exit site is completely healed. The bandage is changed once a week by PD nurses, and it may take 3 to 5 weeks to heal completely. And once you're certified that the exit site is completely healed, you begin daily exit site care at home, and the patient needs to be trained to clean it daily with soap and water, dry completely. We need to put an antibiotic at the exit site. I think putting a drug on the exit site is important, but however, I don't believe it's critical in a well-healed exit site. That the patient, if the patient maintains good hygiene, it is not critical to dress the exit site. But generally, in our unit, 99% of the patients put a dressing on at the exit site. So we are a believer in using antibiotic prophylaxis at the exit site, and a variety of different methods have been used, and this is primarily the rationale for this is that a bacteria that the patient carries, bacteria that cause infection at the exit site, and the patients generally carry this in their areas. And people have used mupirocin at the exit site daily, mupirocin in the nares, or rifampin in the past. What we've known is that whenever you use mupirocin, whether you use mupirocin in the nares or you use the exit site, there's a profound reduction in episodes of peritonitis. These are clinical trials, but in looking at large practices, there have been surveys, for example, that have been published from Scotland and from Austria. Units that use antibiotics at the exit site have consistently lower peritonitis rates than units that don't use antibiotic at the exit site. And we've chosen the rate of applying antibiotic at the exit site. And what we do is actually uses gentamicin. And the gentamicin we use is because of this clinical trial that was published now 6 years ago, in which patients were randomized to apply either mupirocin or gentamicin at the exit site. They expected a reduction in gram-negative infections, but what was surprising is that with use of gentamicin, there was a substantial reduction in infections, not only because of gram-negative organisms, but all gram-positive organisms. The onset seemed to be an increase in colonization by yeast at the exit site. This is exit site infections. We're not talking about peritonitis. We have not seen this. We've been using it now for 5 years in our unit, gentamicin at the exit site. We have not seen any increase in yeast infections, but we had a profound decrease in infections, both because gram-positive and gram-negative infections. And there was we actually never see gram-negative peritonitis anymore. It's been like 4 years since we've had an episode of gram-negative peritonitis. So I'm a strong believer in applying gentamicin at the exit site on a daily basis for all our patients. It's so important that we get antibiotic prophylaxis not only when contamination occurs, but when there are other procedures. Our protocol is to give amoxicillin before dental procedures. We give antibiotic prophylaxis for colonoscopy as well as for GYN procedures. And we have not seen infections around these episodes yet. I think I'll wrap up this discussion of peritonitis by saying that the bottom line again is CQI. You have to know your facility's peritonitis rate. PD recommendations is that the peritonitis rate should be better than 1 episode in 18 patient months. Fortunate right now, our peritonitis rate is running at 1 episode in 50 to 60 patient months. I know that there are many facilities within DaVita that are doing as well as we are. So it is something that we can achieve. Every time that there is an episode of peritonitis, despite what we have done to prevent peritonitis, if it happens, it's important to do a root cause analysis for every case. Why did this patient get peritonitis? Routinely schedule a retraining day after the acute episode subsides and decide whether there is a need for the nurse to do a home visit. It's important to know what organisms are causing infection in your facility, not DaVita-wide, but in your own facility. We review this at least once a year, and whether we need to change what we are doing based upon the organisms that we see. You track what proportion of patients get hospitalized for peritonitis and how many require the removal of the PD catheter. This is a critical component of continually striving to improve outcomes within the facility. And prevention of infection is a key component of patient training. We talked about identifying contamination, exit site prophylaxis, and QI. This last part is to preserve residual renal function. There are numerous benefits of residual renal function that has been shown in many clinical studies. And the bottom line is, if the patient has residual renal function, it makes prescription management simpler. And so we make our patients to keep on having residual renal function for as long as it is feasible. And do for that. There are 2 clinical trials that show that if you use inhibitors of the renin-angiotensin system, you keep on the kidneys working for longer. There's a clinical trial out of Hong Kong in which these are patients treated with PD that had residual renal function of more than 2 ml per minute, which is residual GFR of more than 20 liters per week. That is to ramipril or control, and patients that received ramipril kept on making urine for longer than they were randomized to a control. The study from Japan, in which patients on PD were randomized to receive either an angiotensin receptor blocker, which case was valsartan, as a control, and those that received valsartan had a higher creatinine clearance compared to those that got a control. One of the important things to keep in mind, so every patient who's on PD, as long as there is no contraindication for their use, should be on inhibitors of the angiotensin system, whether it is an ACE inhibitor or an ARB. It is common for patients that have advanced kidney disease for allergists to stop the ACE inhibitors, ARBs, because they get into trouble with high potassium levels, which is appropriate. You don't want the potassium levels to be appropriate. One of the things about PD is problems with hyperkalemia are rare in PD. Very effective in keeping potassium controlled. Not just that, we are more likely to see low potassium rather than high potassium. So I think there needs to be a systematic evaluation that needs to happen about 2 or 3 months from the time the patient starts PD. Whether they are on ACE inhibitors and ARBs, and if they are not on it, they should be on it. It's an important CKI initiative because it is not something that can necessarily be left to the routine clinical care of the patients. This needs to be dependent and implemented systematically across facilities. We have a checklist for physician encounter in which we ask physicians to certify if the patient is an ACE inhibitor or not, and if not, why. Ensure that all our patients actually are on ACE inhibitors and nobody falls through the cracks. There are studies that have shown that cycler patients lose their residual renal function faster than those with CAPD. I'm going to go through the entire content of the slide, except to say that the studies have shown that are of poor quality, and not persuaded that cycler is worse for residual renal function. And we, our facility, leave the decision for CAPD or a cycler to the patient, and then for them to determine 9 out of 10 times. We cannot do it 100% of the time, but 9 out of 10 times we leave it to the patient to decide which one is going to work best for them. There are new solutions that have been introduced in the United States that are considered to be what is called as biocompatible. They have low concentrations of glucose degradation products. And there was this initial study that was meant to claim that if you use these biocompatible PD solutions, you will be able to preserve your residual renal function for a longer period of time. There have been preclinical trials that have been done since then and showed any difference between patients using these low GDP solutions versus the usual solutions that we use, for example, the dextrose-based solutions that we use, the traditional solutions that we use. There is a large clinical trial that has been ongoing in Australia and New Zealand, and we'll see the results of that, but I think I'm not persuaded that low GDP solutions are better. So we use traditional PD solutions, comfortable that these patients would preserve the residual renal function as well as otherwise. It's also important to avoid these nephrotoxic insults, or the patient doesn't get contrast unless they have to. Avoid use of aminoglycosides. It's important to avoid the use of non-steroidals. And these non-steroidals, as you know, are available over the counter, and patients could get them from over the counter without a physician prescription. And so counseling needs to happen to prevent patients from using non-steroidals. Depletion, episodes of hypotension, if I could just go back, episode volume depletion should be avoided because they are hurtful to residual renal function. Urinary tract obstruction, high calcium levels, and finally, I just want to put in a word to avoid withdrawing immunosuppressives in a patient who has a failed transplant. Traditionally, patients that have a transplant get immunosuppressive medications. Because they're now on dialysis does not mean that these medications should be withdrawn. What we choose to do is generally leave at least one immunosuppressive medication on board for patients that had a failed transplant. It's really either cyclosporin or tacrolimus, whichever one they may be on, and we taper off the others. And I think it's useful because if you stop all immunosuppressive medications in a person with a failing transplant, they're going to rapidly become anuric, and that could complicate your prescription management issues. I want to put in a word by saying that we focus a lot on residual renal function in patients on PD. That does not mean that the only way you can do PD successfully is if the patient has residual renal function. That's actually not true. Patients that make urine can successfully maintain on PD for very long periods of time. These are 5 studies that have looked at survival of patients treated with PD that made no urine. And the survival is only slightly worse than those that have residual renal function. And I would just, we have a significant proportion of patients that are anuric that do PD very well. One just needs to be engaged in handling the prescription and make sure that the prescription is right for the patient who's anuric, and we are maximizing solute removal and fluid removal, but it can be successfully performed as has been shown repeatedly. With preserving residual renal function, it's important then to monitor early and periodically. We do our first assessment of residual renal function during the week of training. So usually on the Thursday night of our training schedule starts on a Monday, goes through Friday. On Thursday night we have Thursday through the day, Friday morning, have them do a 24-hour collection of urine, bring it in, so that we know up front how much residual renal function that we have, and that's our starting point. We ensure that every patient is on ACE inhibitors or ARBs if there are no contraindications. It's important to avoid hypovolemia and other nephrotoxic insults, and I've already talked about those that have a failing kidney transplant should continue at least one immunosuppressive medication. Just a quick word on hernia repair in PD patients, because I think there's a misconception that patients that need a repair of a hernia need transferred for hemodialysis for the hernia repair to heal, and the short answer to that is that it is not necessary. If the patient has significant residual renal function, you can just skip dialysis for 1 to 2 weeks and start low-volume PD thereafter. If the patient does not have residual renal function, we follow this protocol that you have available now. This is what was reported by Dr. Borgman, University of Toronto, in which they skip dialysis for 48 hours and then again with intermittent PD, best done with the cycler, which is intermittent PD is 1 liter exchanges, 10 exchanges over 10 hours, 3 times a week for the week. And now switch to NIPD for 4 weeks, and then they can resume full dose PD thereafter. And we implemented that for now 5 years or so, and we never had a patient have a leak or a problem with hernia recurrence when we use this protocol. As the experience from Dr. Borgman, in which they also had no leakage or early hernia recurrence, and they had 50 patients that went through this protocol over a 10-year period. So this is my last slide. These are my takeaway points for you. Fewer patients need to transfer to HD than they used to. Transfers are preventable, primarily by implementing good system practices. Infection is possible, and is perhaps the most important way to lower transfers to hemodialysis. Attempts should be made to preserve residual renal function, and patients don't need to transfer to hemodialysis for surgeries like hernia. Thank you for your attention, and we can open up for Q&A now.
Thank you, Mehrotra. Alicia, please open up our Q&A session.
Absolutely. At this time, I would like to remind participants, in order to ask an audio question, you may press star, then the number 1 on your telephone keypad. We'll pause for just a moment to compile the Q&A roster.
Reminder as well, you can ask your questions in person, or you can type them into the chat box online. We'll wait to answer either question either way.
Once again, to ask an audio question, you may press star, then the number 1 on your telephone keypad. We have an audio question from the line of Sylvia in Mountainside. You're open.
Wondering about patients with membrane failure, because I've been seeing some of that, and we've had patients transfer from PD to hemo because of that.
Right. I think it was covered in, I suspect, greater detail in one of the subsequent presentations.
Okay.
I could just briefly say membrane failure generally means that the patient has become a high transporter. Mm-hmm. Most patients, when they are a high transporter, what they need to do is to do a cycler at night and do long dwell in the day. You need to make sure that they don't carry a dextrose-based dialysate for a long period of time, so that a dextrose-based solution is not in the peritoneal cavity for 4 to 8 hours because they'll reabsorb. You can do it one of two ways by doing that. You can either give the patient a partially dry day. You can patient put in fluid and then drain out and then have them dry the rest of the day. Now, you want to do that only for patients that have significant residual renal function. Patients that have significant residual renal function, then one of the best ways to do that, short of using 4.25% dextrose every day, which I would not recommend, would be for the patient to use codextrin during the day dwell. Some patients in whom fluid management would be difficult make these alterations. But that is a distinct minority. I just want to pitch in a word here when you talk about membrane failure and volume control for judicious use of diuretics. In patients that have some urine volume, you can facilitate prescription management using diuretics. And that will maximize urine volume and minimize the need to generate ultrafiltration with PD. That should be used fairly liberally if possible.
Your question comes from the line of Concepcion in Herspesa. Your line is open.
So, Doctor, I asked this question online, so I will ask it now. You don't have to answer the other one. My question is, do you believe that the lower lock system is as efficient at preventing contamination as the acid mechanisms?
Right. That has been tested in clinical trials. There is no difference in peritonitis rate using the two different systems. We use the lower lock system in our unit.
Okay. Thank you very much. That answers my question.
Once again, in order to ask your audio question, you may press star, then the number 1 on your telephone keypad. We have another audio question from the line of Meg in St. Louis. Your line is open.
Hello?
Yes.
Oh, I came in a little bit late, but I was just wondering, this information is really helpful, and is there any way this slideshow can be emailed to us so we take it to our doctors at our QA meetings?
I believe it's going to be available. Mahela, can you take that question?
Webinars, this one included, will be available for playback on the WebEx system, but we're going to have to get legal compliance approval to release anything via email. Plus, we Dr. Mehrotra's approval as well. It is his presentation.
Oh, okay.
We can talk about that at a later time.
Okay, great.
Shoot me an email if you could.
Sure.
Thank you.
No other audio questions at this time.
Dr. Mehrotra, this is Maela. I have a quick question for you. We wait for more questions to come along. If I am a nurse of mid-sized program, let's say 8 to 10 patients, are there specific things that I should be looking for when a patient has to go on backup hemo in order to make sure that they do come back to PD?
I think specifically what is done on the reason why the patient is in backup hemo, but I think constant engagement and support of the patient, when the patient is in temporary hemo, is critical, as is the issue of what it is the patient is in backup hemo. A lot of the times is sensitive to be on backup hemo is often not necessary. I've already given an example about hernia. For example, that is not infrequently, what to me is somebody who needs to get a laparoscopic cholecystectomy. And the question is, if the patient gets laparoscopic cholecystectomy, should the patient be on temporary hemo? The answer to that is no. If the patient laparoscopic cholecystectomy is using a laparoscope with very small incisions that are made, and we follow the protocol like I presented for hernia for patients that get a laparoscopic chole. I had an email yesterday, for example, from another of my old fellows for a patient who has pleural effusion, likely hydrothorax, and he was ready to transfer the patient to hemo. And I think that patient as well, the patient needs low-volume supine PD for 3 to 4 weeks before you would even determine whether that needs a surgical intervention, but transfer to hemo generally is not necessary. There are circumstances in which backup hemo is necessary, whether it is that the patient comes in with severe hyperkalemia or has peritonitis that requires a PD catheter removal. But I think, getting back to your question, I think constant support and encouragement is what is critical for the patient while they're in backup hemo, because that generates a lot of anxiety and may lead to rash decision-making by the patient at that time.
Thank you.
And if you would like to ask an audio question, you press star, then number 1 on your telephone keypad. And we have an audio question from the line of Pamela and Wilson. It's open.
I'd like for you to review again about the hernia. They're undergoing a hernia repair, and if they've got renal function, how you treat. I didn't catch everything. There it is. I did catch that slide.
Yeah. Fine. So this is significant residual function that is more than 4 ml per minute. Which in this case, it's fine for that patient not to get any dialysis for 1 to 2 weeks. And if concerned about issues, you could just have them come to dialysis facility on a weekly basis, check for fluid accumulation, check for potassium level, if you're concerned about that patient, and start them in low volume PD. Low volume PD is not effective PD. It is something that you want that patient to be on forever. But for a short period of time, to put that catheter, central venous catheter, for a hemodialysis catheter to be placed for the patient to be on hemo, it is much preferable for that patient to do low volume PD. And by volume PD, it's best done on a patient with a cycler, in which you use 1 liter fill volumes, 10 changes over hours, and then fluid during the daytime. And then they can refill those PD after 4 to 5 weeks.
Thank you.
Sure. Something that you can use, for example, we have a patient recently who had a patent processus vaginalis, had fluid accumulation in the scrotal sac. And we get his scrotal sac, the processus vaginalis, tied off. And it is dealing with a peritoneum, but it's just like a hernia. We've talked about cholecystectomy and other things. You can use this protocol for a lot of abdominal procedures. Now, if you have extensive abdominal surgery, if the patient is not a laparoscopic surgery and the patient comes back with a 2-inch or a 4-inch scar, then this is not appropriate. Then the patient should be on peri-hemo. But for surgeries, for the most part, this is okay.
Okay.
To ask an audio question, you may press star, then the number 1 on your telephone keypad.
We do a write-in question, Dr. Mehrotra. I'll go ahead and read that right now. Experience with changing out the PD catheter at a single single procedure in patients in whom peritonitis fails to resolve, and the concern is biofilm in the catheter?
Right. The answer is we have experience in that, and actually a lot of good experience in that. So the simultaneous removal and replacement, we reserve it for two circumstances. The first circumstance is a person getting recurrent peritonitis. It's a relapsing peritonitis. It's either it's a culture negative peritonitis or it is a gram-positive peritonitis. Patient gets infection, you treat it, you stop the antibiotics. 2-3 weeks later, the patient has an infection again. And the second circumstance in which we do it is we have peritonitis either by Staph aureus or Pseudomonas if the patient also has an exit site infection along with it. So a person who has Staph aureus or Pseudomonas and there is an exit site infection along with it, that is another person who is a candidate for simultaneous removal and replacement. When you simultaneous removal and replacement, it is absolutely critical that the patient have no evidence of peritonitis at that time. That there should be, the cell count should be less than 100, and the culture should be negative. What we do is there should be no evidence of peritonitis and continue antibiotics till it gets the surgical procedure. So normally we'll stop antibiotics in 2 or 3 weeks. If we can schedule that surgery in the next 2 or 3 weeks, we'll continue the antibiotics. And continue the antibiotics for up until a week after the simultaneous removal and replacement has been done. For the specific issue of peritonitis is not resolving, if the patient has a high cell count and the cell count is not coming down, that patient should not get a simultaneous removal and replacement. You want to remove the catheter now and wait 2 to 4 weeks before putting in a new catheter. But if you put in a new catheter at a time when there is evidence of infection, then that new catheter will get infected and we keep on getting relapses. So you do it only when peritonitis has settled down on cover of antibiotics.
And to ask an audio question, you may press star 1 on your telephone keypad. We have audio questions at this time.
And Dr. Mehrotra, one more question for you. You mentioned that larger PD programs tend to have patients that transfer over to hemodialysis or used to at a much higher rate than smaller programs. Is there something specific to larger programs? Is it really the patient-to-nurse ratio, or is there something else that we should look for and watch out for as if we belong to a larger program?
So the reason why large programs do better, it's only my opinion, I don't know if that is the case, is because large programs have sorted out the issues that are problematic for PD programs in general. They may have identified a surgeon who does a job of putting catheters. They would have figured out that patients that have hernia do not need to be transferred to hemodialysis, or have in place a better process for CQI. It may have part to do with staffing. So I don't believe it is intrinsically a better qualified nurse or a better qualified physician, as a lot of these system practices that need to be in place for a PD program to be successful. And when you have a critical mass of patients, you're able to do it better than if you don't. And that I personally believe that every PD program should be positioned for growth. And more the growth, the better it is for the program. It's like killing the patients with the rising tide. They're all going to do better.
Thank you. Alicia, do we have any more questions on the line?
We have one more audio question from the line of Meg in St. Louis.
Hi. Yeah, I was just wondering, I was on another WebEx some time ago, several months ago, and the doctor was talking about Lasix and Bumix, diabetes and that, and he had given out some doses, but I wasn't able to get those doses because higher doses than what our physicians seem to be using. Is there a way we could get that information?
So, in clinical studies, the doses that they have used for Lasix are extremely high.
Mm-hmm.
They've used 250 milligrams twice a day. Now, that's very high. I don't use doses that high. What's very important is whatever dose the patient is being prescribed is for ask the patient is when the patient takes the medicine, 2 or 3 hours later, do they need to go pee more? If they go pee more, the diet is doing what it is supposed to do, is to make them pee more. If they are not getting a diuretic response, then they need a higher dose. And I choose not to be prescriptive in this regard. I have patients that I give 20 milligrams of Lasix, even though they have advanced kidney disease, and they pee more. Others that I could give 160 milligrams, and they don't pee. So you have to tailor it to that individual patient. The bottom line of it is that just don't simply have the physician prescribe and have no follow-up as if it's working or not. Just check if it's working or not.
Okay. Now, is there a limit? Let's say the patient urinates 250 cc's in a 24-hour period. Is there a cutoff of when they shouldn't be doing diuretics?
Generally, if the urine volume is less than 100 cc's, it's not effective.
Okay. All right.
No, would not underuse 150 cc's of urine.
Right.
Because for that individual patient, that potentially is another 150 cc's they can drink.
Mm-hmm.
Half a can of Sprite, let's say, not Coke, Sprite. So,
all right. Well,
yep.
It's Dr. Murray. I would comment that in Australia and Europe, 5 milligram tablets for furosemide are available. So, very often on dose of 1 or even 2 grams a day. Very helpful. And we don't see side effects with that. People worry about deafness. I'm sure that only occurs with intravenous furosemide. And there's a pity those tablets are not available here.
Right.
It looks like we have time for one more question. Is there another question out there?
We have further audio questions in queue at this time.
Great. Mehrotra, and if there are no more questions, we'll go ahead and stop here. I want to take a moment to thank everyone again for participating, and especially to thank our speaker, Dr. Rajnish Mehrotra, for taking time away from his busy schedule to speak with us today. Please join us for our next webinar that's scheduled for Friday, January 6th. That's a continuation of our cruise control series. Dr. Mann will be hosting that presentation, and the presentation will cover the time period from 6 months to a year. Again, everyone, and have a great day.